treatment of prostate cancer has become more complex, both in the earliest and in the most advanced stages. And I'll tell you a little bit about our active surveillance program at Johns Hopkins, which has been ongoing for many years now, and it's one of the larger ones in the world. So active surveillance, which we used to call expectant management, with selective delayed early intervention, is definitely an accepted management strategy for men with favorable risk prostate cancer. And I think the goals of any active surveillance program are to prevent overtreatment of clinically indolent lesions and not to compromise the chance for cure in men with clinically significant or potentially life-threatening cancer. The challenge is to actually discriminate between indolent or quiet disease from significant cancers at the time of diagnosis. So before considering a patient for active surveillance at our institution, we recommend to repeat PSA, and we use PHI, Prostate Health Index. You can talk about 4K, PCA3, some other biomarker to sort of confirm this PSA as reflective of the disease state. We assess patient life expectancy, try to estimate that using some of our Social Security life tables. We risk classify the patient per the NCCN classification system. And then we inform the patient using those guidelines and our own experience about some of the appropriate ways forward, whether it's surveillance or radiation or surgery or cryotherapy. We discuss prostate MRI. We generally get a prostate MRI before we consider surveillance long-term, but we can talk about that later. We also perform a confirmatory second biopsy. This came up earlier in discussions today, the idea of genetic testing. We are not doing that routinely yet. There are no guidelines suggesting it should be done at this point. However, we've been studying familial prostate cancer families for 20 years and found the HOXB13 gene in such families. So there's definitely, this is an important patient cohort. But there's something different about the surveillance patient who's on it for a long time and the dense families with genetic predispositions who tend to then get, particularly if they have BRCA1 or 2 or CHEK2, get more aggressive disease. But certainly if they have first-degree relatives, significant family history of breast, ovarian, et cetera, I think genetic testing is very reasonable. We use a life expectancy calculator like this. Many of us just know in our heads how how life expectancy is in the U.S. And then if you have obviously comorbidities, that reduces your life expectancy. So you get a sense of how long someone has to live without the prostate cancer. And then, of course, there's the conventional risk categories, low, intermediate, and high, defined by Dr. D'Amico many years ago. And certainly favorable risk in our setting is a mix of low patients, but we also then substratify that into very low-risk prostate cancer. So this is a concept that one of our pathologists, Dr. Epstein, came up with some years ago, and it's somewhat been validated. It's been put into the NCCN guidelines, but a very low-risk patients would have a non-palpable disease, would have a PSA density of less than 0.15, low Gleason score, and very few cores involved with cancer. And nowadays, we even have noticed in our surveillance, having unilateral disease puts you in a lower risk category than if you have bilateral disease in terms of cancer volume and prediction of upgrading. So if you have these criteria, we call you very low risk. That basically predicts lower tumor volume and low grade in the actual pathology if you were to do a radical prostatectomy. And these are, to us, the ideal candidates for surveillance. Non-palpable, low PSA density, low Gleason, and few cores involved. We then put this together and call this favorable risk, and that is what our surveillance cohort consists of. This slide just shows you that there is a difference in pathologic outcomes when you compare the very low risk and the low risk patient in terms of percentage of Gleason score 7 and percentage of non-organ confined disease. So it seems to be a real discrimination. The ideal active surveillance candidates have this very low risk disease to low risk disease. Obviously, the we want to be less restrictive in our criteria for surveillance in men who have shorter life expectancy. If you have very high-risk disease, we don't even recommend surveillance. You get treated, or if you have no life expectancy, you go on watchful waiting. If you have intermediate risk, then and your life expectancy is less than 10 years, then surveillance is a reasonable option. If you have low-risk disease, less than 15, and if you have very low-risk disease and less than 20-year life expectancy, it's reasonable. I think if you're 45 and you have very low-risk disease and your life expectancy is 30 or 40 years, it's hard to argue that one should start observing cancer at that young age, although certainly you tell the patient treatment is not an urgent thing. It's just you're basically deferring the treatment that will be inevitably coming that patient's way, as far as we can tell. So our cohort is a combination of low and very low-risk patients. It's older than some of the cohorts. Our men are in their mid to late 60s, typically, about 66, 67. And our trigger for intervening is usually biopsy reclassification, which means on one of your surveillance biopsies over time, you see a higher grade or a real increase in cancer volume. We're one of the only centers that considers volume progression. Most really rely on Gleason progression. And I think we're changing and realizing that Gleason grade upgrading is the more dangerous phenomenon. There are review papers you can find that show you the differences between all of the big surveillance cohorts in the world. I just took the first page, which has some of the bigger ones, with Hopkins, Toronto, and Sweden, and a multinational one, as well as a UCSF cohort. And you can see at a glance, I'll just summarize, that the Hopkins criteria for surveillance are amongst the most strict. We don't even use PSA per se, we use PSA density, and we use a lower PSA density cutoff than other places that use, say, 0.2. We insist on essentially non-palpable disease, although we have some patients like this who go into that low risk but not very low risk disease, and we insist on Gleason score of less than 6. Toronto has a cohort where they include Gleason scores of 7, but as we'll discuss, that's changing as they're finding some of those men progress and die of their cancer. So of the four large surveillance programs, you'll notice Hopkins has a fairly low rate in this review of biopsy upgrading compared to the other ones. And again, that may be because our cohort, as I showed before, has a lot of these very low-risk patients. These are men destined not to progress at the same rate as your general low-risk patient. However, we have a little more progression to treatment than some of the other programs. And that's, I think, again, because we considered things like change in volume as significant. So if someone all of a sudden has bilateral disease or one needle has 60% cancer, we tell them, look, you've progressed into a worse state and you should do something about it. Whether that's correct or not, that's just how we've been doing it. So Dr. Klotz and Dr. Carter, who are the heads of the two main, Carter at our program and Klotz in Toronto, kind of have the best long-term data. And it looks as though if you use the restrictive Johns Hopkins criteria, you get about 50% of men progressing to treatment by 10 years, but less than 1% have died or have had metastatic disease. In fact, only literally 1 or 2 men have died in our 1,600 patients series of prostate cancer while on surveillance. Whereas in Dr. Klotz's program, when he gets into the intermediate risk patients, he shows that you get 9% have metastases and 3% have died. So he is no longer really recommending surveillance as it is in the 3+4 low intermediate range. His favorable risk patients also do a little worse than the Hopkins patients because he includes palpable disease and has some less stringent criteria, as we discussed. It's hard to really get a sense of the risks of delaying treatment, but there are some good modelers like Dr. Etzioni in Washington State. And the models, depend on the inputs. You can put in time to biopsy reclassification from Hopkins, time to recurrence after surgery from Capsule, time to recurrence to death based on Hopkins data. And these guys estimated that cancer-specific death over 20 years was 1.6% for treated prostate cancer versus 2.8% on surveillance. Again, I don't understand all the statistics behind this, but this was a sense of trying to figure out if the surveillance makes sense. It looked certainly that our radical prostatectomy treatment would increase life expectancy overall, but by how much? It's a big operation if the modelers tell us we're only increasing a man's lifespan by about 2 months. Men on surveillance lived treatment-free for an average of 7 years from diagnosis if they went on surveillance. And so, one has to contrast these things. The most I can say is that some men just want their disease treated, and some men really don't. And if you can counsel, if that makes sense based on their disease state, I would go with how the man feels. If their disease state does not allow you to comfortably recommend surveillance or comfortably recommend surgery, then you just have to face that and tell them. So I mentioned before the role of MRI and fusion biopsy is kind of evolving very quickly as our radiologists get better and better at doing the protocol properly, the sequence, reading them properly, and get more and more data on what PIRADS 3 and 4 and 5 lesions actually mean and what kind of cancers they harbor. But in active surveillance, okay, this is all active surveillance now, there have been 2 studies I want to discuss. One is from my colleagues at Hopkins, led by Dr. Carter, and that is they decided to look at surveillance patients, men on surveillance for a biopsy, and diagnostics. So men entering surveillance, men getting this confirmatory biopsy, men on surveillance already, and men just on diagnosis. About 50% of the men who were in surveillance ended up having some kind of a lesion. So right there you know that MRI is missing 50% of cancers. Well, the good news, most of those cancers are not significant. MRI is really better to find large tumors, which often are not on surveillance. So each of these men then got a 12-core systematic biopsy plus a targeted biopsy with 2 or 3 needles when there was a target. And it turned out, in the active surveillance cohorts at least, but even in the other, that, and this is a little bit of a confusing graph, but basically targeted biopsy, systematic biopsy is this pink color, and then the targeted biopsy is here, and both biopsies showed something here. So if you just looked at sort of detection of Gleason 7 disease in one of the surveillance cohorts, 18 men had it found by systematic biopsy alone, 3 men had it found by systematic plus the targeted, and only 4 men had it found by the targeted needles only. And that's kind of reproduced in some of the other cohorts, that the role of the targeted biopsy was somewhat limited and statistically did not hold up. So the conclusions our researchers made was that adding the targeted biopsy of the MRI lesion to the systematic 12-core biopsy did not significantly increase the detection of the higher grade cancers in men on surveillance or in men entering surveillance. And that systematic biopsies are essential in surveillance. They miss too many lesions and less sensitive. Now, this was not any kind of randomized study, so let's go to Dr. Klotz from Toronto. Just published in the European Journal not long ago. He took 273 men with low-risk disease, or at least Gleason 6 disease, who were going into consider surveillance. They got randomized to no MRI and then a confirmatory systematic biopsy versus an MRI plus confirmatory biopsy plus 2 cores if any target was found. And in their set, 64% had targets. Again, these men were going into surveillance, so they were not already a surveillance cohort, which explains the slightly higher findings here. The primary outcome was upgrading to Gleason 7 or higher. And interestingly enough, there was basically identical upgrading whether you had your MRI and your targeted biopsy or whether you just had the systematic biopsy. Again, this is not, clearly there's a role for MRI in diagnosis, and we like to get MRIs to make sure there's not a big anterior tumor. But for this kind of entry into surveillance, that is not the test that's going to be a deal breaker, we don't think. Interestingly also, the positive predictive value of this ranged extremely widely depending on the site in Canada. Some sites were very good at getting the lesion, and in some sites, even at PIRADS 4 or 5, only 8% of the time was aggressive cancer, which is lower than it should be. So in some, I would say, recommendations, eligibility for surveillance. In our case, we really favor the very low-risk patients. PSAs can even be up to 20 if the PSA density is very low, although that's relatively rare. And the PSAs are that high, we do talk about getting an MRI. Any low patient, intermediate risk patient that's considering surveillance, then we really look at life expectancy to even consider these intermediate risk patients, and they always have to get an MRI to make sure we're not missing a large lesion that's harboring even worse cancer. In terms of monitoring, the way we do it is every 6 months, traditionally, these guys would get a digital rectal exam and a PSA. Now we're moving into sort of annual exams. We still get the PSA every 6 months, but annually for the exam, because the exams tend not to change very often, and in these parameters. We get a biopsy at least every 2 years. We had been doing it every 12 or 18 months, but in the very low-risk people with negative MRIs or negative, PIRADS 3s, we can do every other year now. Safer, probably every 12 to 18 months, and then biopsies, really probably not even indicated in men who are getting into their 80s and who have a normal MRI and relatively stable PSA kinetics. MRI, basically in my practice, and I think Dr. Carter's as well, we're pretty much alternating MRI 1 year, biopsy the next year. MRI 1 year, biopsy the next year. If the MRI shows something very suspicious that we haven't seen before, then we'll do the biopsy after the MRI. But that's pretty much surveillance. It's blood tests every 6 months, blood tests and an exam once a year, and then MRI alternating with biopsy every 12 months, like that. In terms of criteria for moving in and curing, patient preference is a driver. Some men just get tired of getting biopsied every 2 years. That's understandable. Certainly, and if they're young, that's a lot of biopsies. If they get reclassified from going from very low to low risk, depending on their life expectancy, or if we find any pattern 4, we strongly consider them to have treatment, usually radiation if they're elderly, maybe more surgery if they're younger. PSA's never really been shown to be a good predictor of progression. In every paper that's ever been written on PSA kinetics and active surveillance, PSA alone is not particularly helpful. PSA density is quite helpful, but not the PSA alone. There's too much BPH confounding that. So in sum, what do we watch for? We watch for changes in the exam. That's very rare. We do look for longitudinal increases in PSA, free PSA. We're basically studying this all the time, but they have not proven to be predictive of reclassification. Dr. Tassoyan and I just put a paper out looking at PCA3, which one of our last lecturers discussed, over the long term, and are there changes in these markers over time. Really, it's your PCA3 at entry into surveillance, or your PSA or your PSA density at entry, rather than changes in those things over time that are predictive of you having a bad cancer. It's very rare to develop one on surveillance, even over 10 years, because if you have strict criteria going in, those patients seem to be different than patients who start out with a worse lesion or who had their bad clone form early. In terms of MRI lesions, I think we discussed that. We do biopsy definitely 4s and 5s. We do biopsy 3s as well, but they're less likely to show malignancy, usually less than 50%. And there may be something, again, in a surveillance cohort, the predictive value of a PIRADS 3 lesion is lower than in a first initial biopsy cohort. And that data is coming out. The detection of any Gleason pattern 4 or greater remains the most reliable indicator of adverse pathology, with PSA density as the second most reliable indicator. So I think it's a safe program for low-risk men and for very low-risk men, and it's safe for many low-risk men as well. Life expectancy does play a role, And even absolute age may be a factor, as older men do have more adverse pathology, higher cancer volume, higher cancer grade statistically. I think surveillance requires a confirmatory biopsy, and an MRI and targeted biopsy should be considered in anyone enrolling long-term if there is a PIRADS 3, 4, or 5 lesion. However, remember, the trials I discussed did not show a huge advantage to the targeted biopsy, and they showed that for sure a systematic biopsy has to be a part of that strategy. Follow up with biomarkers at the intervals that I mentioned, and annual or biennial surveillance biopsies should include the systematic and the targeted biopsies if anything is found. That's how we do it. Thank you very much.